Hi friends, today we are going to talk a little about appendix. And appendix lies in the lower abdomen on the right side at the beginning of the large intestine, where the small intestine just falls into the large intestine. The large intestine part where appendix is attached is called cecum. Historically, it was related to the tail. People used to think it to be a vestigial organ initially, but now we consider it to be very rich in lymphoid tissues. So it gives protection against infections, so it keeps us healthy. The problem begins when it gets inflamed. And why it gets inflamed? There are multiple reasons. One of the most common reasons being that there is a formation of a stone by the stools which obliterates the lumen of the appendix. So appendix starts becoming thicker and patients start having pain. So the pain is the first symptom when we diagnose that patient can have appendix. The inflammation is called appendicitis. So we call it acute appendicitis. It is a emergency. So patients have to address it ASAP. Appendicitis in kids. So in kids, it is a little different from the adults because appendix once gets inflamed, it can burst and cause the stools to leak out into the abdominal cavity. In adults, what we have is an organ which is a fatty layer which is attached to the intestines is called omentum, which acts as a policeman and helps decreasing the inflammation. And even if the appendix bursts, it causes a localized inflammation. It doesn't spread to the entire abdomen. In kids, that is not very well developed and it can spread to the entire abdomen, and patients can get into sepsis very early because there is a large area of absorption of the bacteria. Once the appendix bursts, what happens is the stools will start leaking into the cavity of our abdomen. The pain actually begins in the middle of the abdomen and then slowly and gradually it starts locating to the right side. Patients can have vomiting, patients can have loose stools associated with the pain. Patients can have fever also, patients can have vomiting, patients will not like to eat anything. The very simple test is that these patients will have some amount of rigidity. That means the abdomen becomes harder in the right lower abdomen, and when you press and release, the pain increases. This test actually confirms that the patient is having appendix and you need to operate such patients. These patients, as soon as they have pain, we get an ultrasound done, and as soon as the ultrasound shows us that it is an appendix, we prefer to take them up for surgery. In adults, because there is pulse manning, even if it bursts, it doesn't cause that much of an inflammation of the entire abdominal cavity. Still, the patients need to be operated, but operated in the first 24 hours. That is for the best results to come. The second category in adults is when the ladies are pregnant. It's not a very typical, clinical presentation because the appendix and the intestines are pushed out of the pelvis by the expanding uterus. Because of that, it becomes a diagnostic, difficulty in pregnant ladies. Since the time we have been able to do ultrasounds, it has become a little easier to diagnose such patients, and these patients, pregnant ladies, can be operated early and the problems can be addressed early. In the geriatric age group, we have major issues because what happens with age, we do not have that much of pain and it is difficult to diagnose because the clinical features can be very different from a normal, pain abdomen, which is central, then going towards the right side and getting localized. And as you know that in adults, the arteries become harder and stiffer. So what happens is the appendicular artery, which supplies blood to the appendix, gets clogged with clots and the appendix can become gangrenous. Appendix wall will die off and there is immediate leak of the stools into the abdominal cavity, and these patients have very little reserves and they will start deteriorating immediately. We have to suspect appendicitis if the patients are coming to us with pain abdomen. So we can immediately do an ultrasound, we can do the blood test where the total leukocyte count will be raised and patient's pulse will be a little faster than normal, and we can do a CT scan and immediately diagnose and take these patients up for surgery before the gangrene sets in. So that is the best time if the appendix is not perforated, if the appendix is not leaking, to operate such patients. When ultrasounds and CT scans were not there, we were clinically diagnosing these patients and operating them. Now the science has actually revolutionized, and now we do not do in most of the cases an open appendicectomy. So these patients go for a laparoscopic removal of the appendix and the patients are up and above in no time. It is cosmetic, very patient friendly surgery, and the pain immediately disappears. Appendicitis, if diagnosed in good time, can be treated very well. There is only one category where we do not operate the patients, that is called an appendicular lump. What happens is the large intestine, the small intestines, the omentum will come and form a lump in the lower right abdomen so that to protect, even if the appendix bursts, it doesn't leak. Patients who have a lump are put on what we call is a Ochsner-Sharon regime. That means they are kept on antibiotics, they are kept nil orally for a few days, maybe 5 days, maybe a week's time. So the inflammation starts subsiding, and these patients are operated only after 6 to 8 weeks once the inflammation has completely subsided. Actually, the risk in operating a lump is because the adhesions which form, that everything is clamped together, there is a risk of injuring vital structures. That means you can injure the small intestine, you can injure the large intestine iatrogenically. That means a surgeon while operating can injure these structures. So that is why the decision is taken in the interest of the patient to defer the surgery for 6 to 8 weeks. Another acute condition which can happen is patients can form a appendicular abscess. That means there is a lot of pus around the appendix. In such cases also, it is very difficult to identify the appendix. So what is done is we just drain the abscess at that point of time, leave a drain, and come back once the inflammation has settled down after 6 to 8 weeks. How do we operate? We do a quick diagnostic laparoscopy. That means we do a minimal invasive surgery or a keyhole surgery where we put in a telescope through a port and 2 to 3 hand instruments where we handle the tissues surrounding the appendix and remove the appendix. This was a little bit in short what I wanted to talk to you about the appendix and the inflamed appendix, which is called appendicitis. Thank you. If you have any questions, you can get back to us.